What is the blood supply of visual cortex is the next important question. What is your guess? Classically posterior cerebral artery. Then about cornea. Why we can do corneal transplantation so easily unlike kidney transplantation? Because it is avascular, corneal transplantation become more easier is what you need to appreciate. And then in that case, if it is avascular, how does it get the air? Oxygen, because it breathes the air is what you have to basically remember. Then what is the nerve which supplies the cornea? Anterior ciliary nerve, which is the branch of the ophthalmic division of the trigeminal nerve. You know what is the corneal reflex? Afferent and efferent. So basically you have two eyes, and whenever you touch with a cotton wasp, then the eyelids close in both the eyes. What is the reason? From the cornea to the brainstem, the trigeminal carries the sensory thing, and in the brainstem it will cause both the facial nerves to send the signals to both the eyes for the eyelids to close. So if you touch with a cotton wasp, sensory will go and make both facial nerves to close both the eyes. If there is any block in this afferent is formed by fifth cranial nerve. Then what will happen if you touch with a cotton? The ipsilateral eye doesn't close, and also contralateral eye also doesn't close. Whereas if there is any problem in the efferent, that is the facial nerve on this side, then if you touch it, then the signal is going up, but that eye is unable to close because facial nerve is injured, but the other eye will be able to close because the other eye's facial nerve is intact. So to know whether afferent of the corneal reflex is problematic or efferent, check whether there is a loss of only ipsilateral corneal reflex or both ipsilateral and also consensual corneal reflex. That's what you need to basically check. So what is the nerve supply, doctor? It is the anterior ciliary nerve. Then if you look at the nerves going to the cornea, they will typically branch themselves and forms a plexus. And what is the condition where there is a hypertrophy of those corneal nerves? Endocrinology mein you studied Men's syndrome, Marfanoid habitus, lumpy bumpy neuromas, enlarged corneal nerves, right? So these are all the things that you need to remember. What is angle kappa in the visual axis? Very simple. Whenever you are looking at any object and fixing your eye, there is an axis which is called the line of sight. Then, but the globe of the eye is what? A global structure, a globe-like structure. So through the pupil and like earth, which will not be, it is not rotating straight, it is slightly inclined and rotating, no, earth. So the axis passing through the pupil will have a different axis. So the angle between the pupillary axis and the line of sight is basically called as kappa angle, is what you have to basically remember. Usually this kappa angle is about 5 degrees, is what you need to understand. So what is the difference between the globe of a adult versus the globe of a child? If you take the globe of the child, the kappa angle is larger than the adult. It is about 10 degrees because his pupillary axis is more deviated away compared to that of the adult. So you must know what is kappa angle, what is the value in the adult and a newborn baby very clearly. Then doctor, whenever kappa angle is large, that means your visual axis is straight and your pupillary axis is deviated somewhere away from the midline. Then what will happen if you happen to throw the light into the retina? Typically the pupillary center and the visual axis will be found away from one another, separated from one another. Whenever you happen to throw the light, whenever larger kappa angle is there, is what you have to appreciate. So whenever you throw the light and it is not falling in the center of retina but deviated away, right? Generally it happens in the conditions like squint. But here, though the squint is not there, because of a larger kappa angle, whenever you throw the light, it is not falling on the center of the retina but little away. Hence it is also called pseudo squint. So pseudo squint is a state of a larger kappa angle, is what you have to basically appreciate. Now doctor, you are having a optic disc. The optic disc has got a neuroretinal rim. So where is that neuroretinal rim is thick? Thickest in which aspect? Rim is what? A circular structure. It has got an inferior quadrant, superior quadrant, nasal quadrant, temporal quadrant. Out of the four, which is thickest, which is thinnest, is what examiner is interested to know about. So if you look at a normal optic disc, there is an area which is called as neuroretinal rim surrounding a central area which is basically called the cup. So the entire diameter is basically optic disc and the central part of it is cup. Whenever we calculate cup disc ratio, why cup disc ratio is important? Suppose if glaucoma like condition is there, then this cup part will enlarge and the neuroretinal rim become thin. Okay, so that is the reason we should always evaluate cup disc ratio ultimately. Give me the board. How will you calculate the cup disc ratio is the important question. So you have a neuroretinal rim and you are having an optic disc. Will you take into consideration the horizontal diameter or the vertical diameter of the cup and disc and compare? Vertical diameter. So whenever there is an expansion of the central disc, thinning of the neuroretinal rim, as in the case of the glaucoma, then you need to calculate the vertical diameter of this enlarged central disc, central cup, and the vertical diameter of the disc, and calculate the cup disc ratio. Okay, so that is one point that you need to appreciate. So this is how a normal cup disc looks like. This is how a abnormal cup disc looks like. Now the question comes, in the cup, in the disc part, the neuroretinal rim part, is the inferior aspect thicker, nasal aspect, temporal aspect, or superior aspect? Which is thicker in this diagram? Inferior. So that is the reason, what is that rule called? ISNT rule. I is inferior thickest, then second thickest is superior, then third thickest is nasal, and thinnest is temporal. So this is what you have to remember and go for the exam. And if you look at the neuroretinal rim, it is typically orange or pink in color, and the inferior border is the broadest and the thickest one of all the borders in the circumferential structure of the neuroretinal rim, is what you are ultimately going to remember. So you are having an optic disc Then you are having macula lutea. In the center of the macula lutea, what do you have? Fovea. Fovea speciality is no rods, only cones. What is the speciality of optic disc? No rods, no cones also. It has got only blood vessel centering, optic nerve leaving. Then around that, within that optic disc, you have got a thin neuroretinal rim. There you are having, but the central part cup is there, no? That doesn't have anything. And that enlargement of that cup is the blind spot of the optic disc. Enlargement of that blind spot, if it occur and the rim part thins down, that is the consequence which you will see in case of glaucoma, is what you have to appreciate. Now the question comes, if there is no glaucoma, if you take the vertical height of the cup versus that of the disc ratio, what is a regular non-glaucomatous disc vertical diameter will be? It is around 1.5 millimeters is the normal median vertical diameter of the disc, not cup, is what you have to remember. So you have a cup, you have a disc. Vertical diameter of the disc is 1.5 millimeters in a normal eye, is what you have to remember. So what happened in glaucoma? The rim thinned out and the central cup has undergone enlargement. Blind spot got enlarged. That's what you are typically finding it. Now doctor, at one point of time in glaucoma, the entire neuroretinal thing becomes so destroyed. What you will have is the entire space is occupied by cup only. Cup is the blind part, blind spot is what it will occupy most of the times. I mean in glaucoma, in the severe stage. Now the question comes, what is the normal cup disc ratio and when do you call it as a enlarged blind spot in glaucoma? If the cup disc ratio is more than 0.5, that means if the cup is occupying around more than half the space of the disc, then you call it as glaucoma. Okay. So small cup disc ratio, when do you call small disc? Typically small disc also have small cups and the cup disc ratio is around 0.35. Large disc have a large cup and the cup disc ratio is around 0.55. And only 2% of population only will have cup disc ratio more than 0.7 is what you need to remember. Okay. So even in our class also, 100 class mein how many are going to get in first attempt? 2 or 3 people only, no? So tell that fellow's cup disc ratio may be very high. So that is the reason he read more faster than what I was reading. That's the reason he got the seat. 2% will have very big cup disc ratio. Then whenever you are examining the two retina, what is the best comparison? Every time you will take a measurement and try to do cup disc ratio calculation while doing fundoscope. No. You have 100 patients in OP, doctor. Put, you should see. Right? Fundoscopic examination should be such a practice that until you get a cervical spondylosis or you diagnose at least one glaucoma every day, whichever is earlier. That many cases, every opportunity you should keep seeing into the fundus. So you should compare the the disc size, cup size in both the eyes, and any discrepancy between the two of about 0.2 mm is sufficient for you to suspect that there is possibly a raised intraocular pressure in that eye where there is a larger cup, is what you need to remember. Glaucoma is called the killer disease. silent killer. People only will have little headache, and for that headache, if they fail to go and get evaluated the intraocular pressure of the eye, only after the blindness happen they end up in discovering it. That's the reason, as a primary physician, you must be sure about the basics of ophthalmology. Now doctor, the muscles of accommodation are typically innervated by the nerve which is passing through which nucleus? Edinger-Westphal nucleus. Now comes a very important question. What is the pathway of light reflex? What is the pathway of accommodation? First, there is a difference between the two. Do you know that? Assuming that you know that. Light reflex means you throw the light, pupil constricts, it don't want to see all the light, right? Not only same side pupil constricts, other side pupil also constricts, which is called as light reflex, consensual light reflex. Then what is meant by accommodation? Basically, whenever you are reading the book in the reading room, the more closer you are looking into most common investigation of choice, etc., into the book, what will happen to your pupils? There are two things, doctor. One, beautiful things to see in the reading room, some dirty things to read in the book. But suddenly our distant vision to near vision we have to focus. When we need to focus, eyes need to accommodate. They have to adjust, leaving all the beauty part of the life and going through the unnecessary academic notes. So what will they do? They constrict, and there is a contraction of our ciliary muscle, and the two eyes come close, which is called convergence. Only when all these things happen, then we can read the dirty things of the book. Okay, pupils constrict, convergence, and contraction of the ciliary muscle. That is what you need to basically remember. What is the importance of the contraction of the ciliary muscle? Why it will help in accommodation? Fundamentally, in the eye, the lens is being suspended through suspensory ligaments. The curvature of this lens is decided by the ciliary muscle contraction. Suppose if the ciliary muscles happen to contract, what will happen? Will it flatten or will it slacken? Slacken or flatten? Come on. It is tightly held, doctor. Contraction of the ciliary muscle is there. So that alters the curvature. Okay. So alteration of the curvature will change the refractive power of the lens, obviously, because altering the curvature will change the focal length of the lens. Focal length is the one which decides the power of the lens always. So the ciliary muscle contraction is required for altering the curvature of the lens and leading to change in the dioptric power, so that person can focus on the nearby object. So that is the idea behind what accommodation reflex is, what you have to basically appreciate. Now, how does accommodation reflex basically occur? We are talking about the pathway. First, you looked into the book, leaving the beautiful thing far behind, far ahead of you. Then the book looked blurry. Your eyes are not yet accommodated. That blurred retinal image will go to optic nerve from the retina. It will go to optic chiasma. From optic chiasma, it will pass through optic tract. It will reach the thalamus, lateral geniculate body. From there, it will pass through optic radiation, and then from there, it will go to primary visual area, which is located in the brain at the level of area 17. It will also report about that blurring image to the occipital lobe, where and also to the association visual cortex is located in area 18 and 19. 17, 18, 19 are the three areas to which this blurred image will be reported by our visual pathway. Then immediately what will association area and the primary visual cortex should react to this situation. What will they do? They will tell. Obviously when a Inspector General is reported about a crime, what he will tell? He will call his Circle Inspector or DSP. So it will tell area 8 once more, which is located in the brain, which is called the frontal eye field area. That's the reason frontal lobe is also important for our controlling of our ocular movements. Frontal eye also is important. That part of the frontal lobe is called as frontal eye field area. So the frontal eye field area will in turn tell the oculomotor nerve, the branch of the oculomotor nerve which is supplying the medial rectus, that see, the retinal image is blurring, I got information, and you ask the eyes to converge. So the medial recti will typically lead to the convergence of the eye by causing the adduction of the two eyeballs. Got it? So who is telling in a accommodation reflex for the convergence to occur? It is the frontal eye field area, which was informed by the 17, 18 and 19. Then the 17, 18, 19 also will send one phone call to the midbrain to superior colliculus. Superior colliculus sustadi, inferior colliculus intadi. So inferior colliculus is about what? Auditory pathway. Superior colliculus is seeing pathway, visual pathway is what you have to basically remember. So the superior colliculus in the midbrain in turn will tell to the Edinger-Westphal nucleus, which is the nucleus for third cranial nerve. That in turn will send fibers to ciliary ganglion. Ciliary ganglion will send fibers to sphincter pupillae muscle, and sphincter pupillae will undergo contraction and that lead to meiosis. Okay. Superior colliculus tells Edinger-Westphal nucleus, Edinger-Westphal nucleus tells to ciliary ganglion in turn will tell constrictor pupillae, because constrictor pupillae are supplied by whom? Oculomotor nerve. Oculomotor nerve's nucleus is Edinger-Westphal. So Edinger-Westphal tells ciliary ganglion will tell constrictor pupillae will cause the pupils to constrict. And ciliary ganglion also sends fibers to ciliary muscle. Ciliary muscle is what? Once more supplied by oculomotor nerve, and the ciliary muscle will contract and that will increase the curvature of the lens, and it also increases the refractive power of the lens. Is what you have to basically remember. Okay, doctor? That means if the ciliary muscle contracts, what is happening to the curvature? It is becoming more curved. The lens is becoming more curved, right? Is what you need to remember. So you may, how contraction of ciliary muscle lead to increased curvature? Contraction of the ciliary muscles will relax the suspensory ligaments and make this lens to become more compact and curvature increases basically. That's the point. Okay. How many didn't understand? सर आप बताते हुए चले गए सुपीरियर कॉलिकुलस कहाँ है मालूम नहीं. Where are you leading us? Are you sure? How many are not yet happy? Sure? Now tell me, for accommodation reflex, is the brain is required? Suppose if my brain get a stroke in visual cortex and occipital lobe, will my accommodation reflex get affected? Yes, it gets affected. At least if you answer that, then I know that you know that there is a information going to brain and coming down back and how it is passing through. Okay. Online students, please punch. Could you follow what I said? Yeah. We will take a second round. Eye is there, doctor. There is a retina in the eye. From the retina, optic nerve comes. I am once more polishing the same shoe. From retina, from optic nerve, it is becoming what? Optic chiasma, right? Then from optic chiasma, what is this which is leaving called as optic tract, right? And typically this optic tract will reach a location in the thalamus, and from thalamus it will go to the brain. So if there is any blurring of image while you are reading of a book, that will go through this pathway through the thalamus and ultimately reach where? The visual cortex. Then from the visual cortex is in which area? Occipital lobe, where you are having 18 and 19 areas, and primary visual cortex, which is area number 17, 18, 19 are informed. Then the 17, 18, 19, what will they do? They will inform the frontal eye field area, which is basically called area 8. Then what will area 8 has? It has connections with the midbrain. In the brainstem you are having midbrain where 3rd and 4th cranial nuclei are there. You are having the pons where 5th, 6th and 7th are there. And then you are having 8th, 9th, blah blah blah, which is not required for ophthalmology. Right? So this 3rd cranial nerve is being controlled by this frontal eye field area. Okay? So it will tell the 3rd cranial nerve nucleus that there is a blurring of the image. So this 3rd cranial nerve nuclei ultimately supplies the eye. What does it supply? Most of the intraocular muscles except the superior oblique and lateral rectus. So it is supplying ultimately medial rectus, no? So it will tell the medial rectus to do the adduction of the eye. And this area 8 will not only tell to the same eye's 3rd nucleus, it will tell the other eye's 3rd nucleus also. Both the eye's 3rd nucleus are being instructed by the frontal eye field so that they tell their respective medial recti to cause the convergence of two eyes. So this is one aspect of it. Khatam? Then what is the other aspect? Typically at the level of the midbrain, you are having colliculi. You have one superior colliculus, inferior colliculus. Superior colliculus is important in the visual pathway. How is it important? This 17, 18, 19 will tell the superior colliculus about the blurring of this image. Superior colliculus in turn in the midbrain level you are having Edinger-Westphal nucleus, which is the oculomotor nucleus of the oculomotor nerve. And Edinger-Westphal in turn will go to a place called ciliary ganglion. From ciliary ganglion, the short ciliary nerves will come to the eye and supply the sphincter pupillae muscles. And the sphincter pupillae muscles will cause the constriction of pupil. So, from the brain, superior colliculi, Edinger-Westphal, ciliary ganglion, short ciliary nerves, sphincter pupillae, pupillary constriction. So that is how pupillary constriction is the part of the reflex. The same ciliary nerves will also supply ciliary muscle, which is there in the eye, and ciliary muscle contraction will lead to relaxation of suspensory ligament and cause the curvature of lens to increase, and dioptric power of the lens will increase, and then the person can focus the book. That is the whole idea. Okay. So this is typically how the iPhone called iPhone 6s will be working, so that we are able to read properly is what need to be remembered. Light reflex इतना लंबा नहीं है. Light reflex में क्या होता? More simple things will occur. Brain का जरूरत ही नहीं है. Light reflex is like our PG entrance exam. At the level of brainstem only, most of the MCQ should be answered. Brain association areas, sensory cortex, you are smelling the answer, you are hearing the music of the question. वो सब एग्जाम में हो रहे बोले तो सीट इस जमाने में नहीं आएगा, है? तो brainstem level only it will happen. So basically you are having retina, you are throwing light through optic nerve, it is reaching optic chiasma and then it is going up. While going, it will slip the fibers at the level of the midbrain. In midbrain, inside the midbrain, you have a nucleus called pretectal nucleus. So it will slip fibers to the pretectal nucleus, which is tectum tegmentum. किसको होता है डॉक्टर? आफ्टर ऑल न्यूरोएनाटॉमी में पढ़ा ना, tectum tegmentum होता है midbrain को, brainstem में. Roof and floor are there for midbrain. So there you have pretectal nucleus. So it will throw fibers to pretectal nucleus. Then this pretectal nucleus, what it will do? It will send fiber to the same side Edinger-Westphal and the opposite side Edinger-Westphal को भी. अजी सुन लीजिए, आंखें ऊपर, रोशनी लग गया, time for constriction बोल के, it will make one announcement to the other Edinger-Westphal. So how does consensual light reflex occur? If you throw light on one eye, how other eye is informed? Because of pretectal nucleus throwing info to both sides Edinger-Westphal, right? From Edinger-Westphal, remaining part of the story you know, right? नागपुर आने के बाद भोपाल कैसे जाना आपको मालूम है ना, हाँ? तो it will go to where? Come on, sing along. Ciliary ganglion, and from ciliary ganglion, short ciliary nerves will go and supply sphincter pupillae, and that lead to development of pupillary constriction. If somebody lost his light reflex, what could be the possible reason for losing light reflex? If you are throwing light and his eyes are not constricting, possibilities क्या होता? पहला उनका retina मर गया. There may be a problem in retina, so that light though you are throwing, it is not perceiving that it is light. Optic nerve, if there is any problem also, light reflex get affected. Optic chiasma, or if there is any problem in optic tract, or problem in pretectal nucleus, or in Edinger-Westphal, or in ciliary ganglion, or in short ciliary nerves, any of them can lead to loss of light reflex is what you have to basically remember. So why we are spending so much time to become very sure about this is, yeah, ultimately pupillary, there are some abnormalities of the pupils. To understand that, you should thoroughly understand what is accommodation reflex, what is light reflex. Okay, because there are some conditions where light reflex is present but accommodation is absent, accommodation is present but light is absent, and both of them are lost, etc., etc. Now let us see. If the optic tract has a problem, where is optic tract? After optic chiasma, you have optic tract. Then you get Marcus Gunn and Wernicke's hemianopic pupil. If there is any problem in the pretectal nucleus, then what you get is called as Argyll-Robertson pupil. Then if there is any problem in the ciliary ganglion, then what you get is called as Addy's pupil. That's the reason you must know each of these pupillary abnormalities, where is the lesion located? You are sure now? Because same thing he will simply ask as a MCQ tomorrow. Marcus gun pupil, where is the problem? What is your reflex answer? Optic tract. Wernicke's hemianopic pupil, optic tract. Then Argyll Robertson is pretectal nucleus. And ciliary ganglion is addy pupil. So please don't forget, one question is going to come. Now, who maintains the transparency of cornea? I am very happy to see 43 online viewers. So when I started this DNB review session, I was thinking, is it really, will really people attend the class with only 1 month ahead of exam? But I was being advised that you should start it definitely only 1 month before exam. Because that is the time where you want to leave everything and sit on a class even on a working day. Right? So after this is over, we will start the APPG. Is Sunday better or Monday, Tuesday is better? You should give me a feedback and a proper advice. But Sunday, our mock test, without doing mock tests and fighting on 200 questions, oh, Ravivar beetega hi nahi. So that's the reason working day is better, because that is the point where all people who are really committed for exam leave all the things and sit, and those who missed it because of the duties, they can always review it on an online video library. So that's the plan. Now doctor, what is transparency of cornea? Mainly because of which layer? It is the endothelium which will basically maintain. There are lamellae which are there in the cornea. That proper lamellar arrangement is responsible for maintaining the transparency. Then one more thing about endothelium is, it constantly maintains a state of dehydration. Endothelium is like a slim housewife. It doesn't want to pick up any weight at all. It doesn't eat at all. Even little eats also, she will do immediate jogging, so that when evening society party is there, she really wants to look tip top. So endothelium constantly uses a active pump to pump out the water out of it, and any accumulation of the water into the endothelial cells will lead to loss of the transparency of the cornea, is what you have to basically remember. Then what is the innermost layer of the corneal epithelium? What is your answer? Already in the form of layers we studied membranous layer, where you are having melanin pigments, pigmented layer is the innermost. But if you look at the histological structure, then it is the columnar cells that are the innermost layer, is what need to be remembered. So fundamentally, you can remember the cornea layers. Sorry, I am talking about earlier what? You are not objecting. I went into some other thought in talking about retina while I am talking about cornea. Sorry. You observed or not? But you didn't say. Chhod do. Anyway, let a maniac continue in a maniac way. जो हमको चाहिए वो ले लेंगे, बाद में देख लेंगे. So suddenly I am realizing that I am talking about retina while talking on cornea. So okay, all right. We are talking about cornea, right? So A, B, C, D, E. A होता है anterior epithelium. Epi is above. So the anterior most layer is fundamentally what? Epithelium. Then comes the Bowman's membrane. Then comes C is corneal stroma. D is Decimet's membrane. And E is endothelium. So that is how the layers of cornea, the 5 layers of cornea. Vinod is saying, let us have some special AIPG ME session also. Yeah, definitely for next AIPG ME, because already December All India entrance is coming, no? So there are two things of winning entrances, whether you like or not. Reading a lot and reading specifically. After reviewing the previous questions of that particular entrance, and then little slight broadening of some areas where we are totally clean bold and still be confident, go to the exam and crack. That is also an approach. There are some smart people who studied not more than 200 hours without even a sweat molecule coming out. Still they are in the top 100 ranks. Smoothly went and cracked exam. The reason is they know how to group up their time. That's very important. You see so many questions on anatomy, but when we open Parson, we any ophthalmology book, we don't think that this many questions come on anatomy. Out of 10, 1 seat anatomy के लिए भर्ती हो गया. 1 is for glaucoma, 1 is for cataract, 3 out of 10 is predictable. Like that, 10 out of 10 are also predictable. If you know what are those 30 topics from which these 10 are commonly coming in DNB. Okay, doctor? Now, each of these layers of cornea को एक दो specialities है. वो क्या है जरा हम देखना पड़ता. Epithelium. What type of epithelium is the corneal epithelium is a favorite question. It is a stratified squamous epithelium. And you have a conjunctiva. What is meant by limbus? Cornea and sclera meet at one point, like India Pakistan border. So that is basically limbus. Okay. So at the point of limbus, the conjunctival epithelium merges into the corneal epithelium, is what you need to appreciate. Now, if you look at the epithelium of the cornea, it has got 5 to 6 layers of cells. And the deepest of all the cellular layers within the corneal epithelium contains columnar cells. The next 2-3 layers are called umbrella cells, and most superficial 2 layers are flattened cells. That's how the epithelial layer of the cornea has 3 different layers within it. And the examiner's question is, in that epithelial layer of the cornea, in those 3 layers, which is the deepest of the 3 layers? Cornea itself is a layer. Right. In that layer there are 5 layers. In that 5 layers epithelial layer is there, which has got 3 layers. In that the deepest layer is columnar layer. समझ में आ गया ना? That is called entrance. Where is the Did they ask about endothelium? Corneal epithelium. Okay? एंडोथेलियम इज सिंपल फ्लैट लेयर. एंडोथेलियम को उतना लेयर्स है तो हमको दिखाई नहीं देगा. सो देन बाउमेंस मेम्ब्रेन, इसके बारे में एक दो बातों की परिचय होना चाहिए. इट इज द एसेल्युलर मास ऑफ कंडेंस्ड कोलाजन फाइब्रिल्स. इसमें सेल्स नहीं रहते, खाली कोलाजन फाइब्रिल्स रहते. तो दैट इज द रीजन they call it a membrane, they don't call it a layer. Bowman is called a membrane, and it is not a true elastic membrane, but it is a condensed superficial part of the stroma, because after the Bowman's membrane, what do you have? Corneal stroma. So corneal stroma superficial most part will condense, and that will form the Bowman's layer. So it is not a true elastic membrane, it is not a layer, but it is called Bowman's membrane. That's the point. Then one more thing is, It is this Bowman's membrane which is responsible for all the resistance to infection, because our cornea is exposed to lot of infectious things in the world, no? Some beautiful, some ugly, whatever it is. Our Bowman's membrane is the one which makes the infection non-penetrable. And one more thing is, if the Bowman's membrane is destroyed, it will not regenerate because it is acellular. शू टीयर हो गया तो रिजनरेट होता क्या? वो खाली लेदर का लेयर है. So इसलिए Bowman's membrane also is a acellular layer. If it is torn forever. That's the point you need to appreciate. Then comes the stroma. It is around 0.5 mm in thickness. 90% of cornea is, after all, it's stroma only, is what you need to remember. And what does it contain? It contains the lamellated pattern of collagen fibrils which are embedded in a hydrated matrix of proteoglycans, is what you need to remember. Then comes the Decimet's membrane. What are the 2-3 points of speciality? Trauma, chemical agents, pathological process, this Decimet's layer is very resistant. Decimet's layer means, you can remember, it is like a basement of a apartment. It's very resistant, right? But sometimes if the weakening of cornea happen and the pressure in the eyeball is trying to herniate the globe, at most Decimet's membrane will still take all that load and form a decimetocele. So that's the point you need to appreciate. And it also contains collagen and glycoproteins. But what is the difference between Bowman's membrane and Decimet's membrane? Decimet can regenerate, Bowman can not regenerate. B is birth, D is death, but reverse is true. Death can regenerate, birth cannot regenerate. Bowman's doesn't regenerate, Decimet's can regenerate, is what you need to remember. And already we know what is meant by Schwab's line. Now comes the endothelium. Endothelium is a single layer of the polygonal cells. If you do slit microscopy, then you can be able to see it like a mosaic pattern. And there are about 3000 cells of endothelium for every millimeter square in a young adult. And as we keep advancing in our age, our endothelial cell density will keep decreasing. But unless that decrease is decreased by 75% of endothelial reserve, then only cornea will compromise. So that is one beauty part about the endothelial part. And these endothelial cells have an active pump mechanism, and that prevent water from stagnating in the endothelium, and that is responsible for our transparency of the cornea, is what you need to remember.